You're 75 years old, feeling pretty good for your age. You go in for your routine checkup, and your doctor recommends a screening test. Sounds responsible, right? But here's what nobody tells you. That test might lead to treatments that are riskier than the disease itself. Stay with me, because what I'm about to share could literally save your life or the life of someone you love. We're talking about 5 common medical screenings that doctors often recommend for seniors. But the shocking truth is, after age 70, these tests might cause more problems than they prevent. And before you click away thinking this doesn't apply to you, remember your parents, your grandparents, or even you in the future could be making critical health decisions based on outdated medical advice. So let's dive into the truth that the medical establishment doesn't always make clear. Now, I need you to understand something crucial before we continue. I'm not some conspiracy theorist telling you to avoid all medical care. Far from it. What I'm sharing today is based on actual medical research and guidelines from organizations like the American Medical Association, the U.S. Preventive Services Task Force, and leading geriatric specialists. The problem is, many doctors still order these tests out of habit, or because they're worried about liability, or simply because they haven't kept up with the latest research on senior health. And seniors themselves often think more testing equals better health care, which sounds logical but isn't always true when you're over 70. Let me paint you a picture of why this matters so much. Every medical test is a domino. You knock over that first domino by getting a screening, and sometimes it sets off a chain reaction you never anticipated. A positive result leads to more invasive tests. Those tests lead to procedures. Those procedures come with risks, infections, complications, side effects from anesthesia. And here's the kicker. For many seniors, you might be treating something that would never have caused problems in your remaining lifetime anyway. It's called overdiagnosis, and it's a massive problem in medicine today, especially for older adults. So let's get into the first screening you should probably avoid after 70, and this one surprises most people because we've been told for decades that it's absolutely essential. Routine mammograms for breast cancer screening. Before anyone accuses me of being anti-women's health, hear me out completely. For women in their 40s, 50s, and early 60s, mammograms save lives. The evidence is clear on that. But after 70, especially after 75, the equation changes dramatically. The U.S. Preventive Services Task Force says there's insufficient evidence to recommend routine mammography for women over 75, and many geriatric specialists suggest that even between 70 and 75, women should carefully discuss the pros and cons with their doctors rather than automatically continuing screening. Here's why this matters. First, breast cancer grows much more slowly in older women. A small tumor that might be detected on a mammogram could take 10 to 15 years to cause any symptoms or problems. If you're 76 years old and your life expectancy is another 10 years, you might literally die of something else before that cancer would ever have affected your life. Second, the false positive rate doesn't change with age, but the consequences become more serious. A false positive leads to a biopsy, and for a 75-year-old with other health conditions, even a biopsy carries risks of infection and complications that are much more significant than for a younger woman. Third, finding cancer leads to treatment and chemotherapy. Radiation and surgery are all much harder on a 75-year-old body than a 55-year-old body. The treatment itself could reduce your quality of life or even your lifespan more than the slow-growing cancer would have. Think about it this way. Imagine you're 78 years old. You feel fine. You're living independently. Enjoying your grandchildren? You get a routine mammogram that finds a small tumor. Now you're facing surgery, possible radiation, maybe hormone therapy with side effects. Your recovery takes months. You lose your independence temporarily. You develop complications. And here's the tragic part. There's a real chance that tumor would never have caused you a single problem if you just left it alone. This isn't theoretical. studies have shown that a significant percentage of breast cancers detected in very elderly women are these slow-growing types that wouldn't have become life-threatening. Now, does this mean no woman over 70 should ever get a mammogram? Absolutely not. If you have symptoms, a lump, discharge, pain, skin changes, you absolutely should get checked out. If you have a strong family history of aggressive breast cancer, or you have a known genetic mutation, the calculation might be different. The key is this should be an individualized decision based on your overall health, your life expectancy, and your personal values, not an automatic screening that happens just because you're a woman and you're breathing. Let's move to the second screening that often does more harm than good after 70 PSA testing for prostate cancer in men. This one is even more controversial than mammograms, and the evidence against routine PSA screening in older men is actually even stronger. The prostate-specific antigen test measures a protein in your blood that can be elevated when prostate cancer is present. But here's the problem. It's also elevated by lots of other things that aren't cancer at all. Prostate enlargement, which is totally normal with aging. Infections, even recent sexual activity can temporarily raise your PSA. The statistics on PSA testing are pretty damning when you look at them honestly. For every 1,000 men aged 55 to 69 who get screened for 13 years, about 1 death from prostate cancer is prevented. One, but in that same group, hundreds of men will have false positives. Dozens will have biopsies that find cancer that would never have harmed them, and many will undergo treatments that leave them with permanent incontinence or erectile dysfunction. Now stretch that out to men over 70, where prostate cancer grows even more slowly and where life expectancy is shorter, and the math gets even worse. Here's something most men don't know. The vast majority of men who live to be 80 have some prostate cancer cells if you look closely enough. Most of these cancers will never cause any symptoms, never spread, never affect their lives in any way. They'll die with prostate cancer, not from it. But once you do a PSA test and find an elevation, you've started that domino effect I mentioned earlier. Biopsy, diagnosis, and then you're facing an impossible decision. Do I treat this cancer that might never hurt me, but the treatment will definitely have side effects? Or do I live with the psychological burden of knowing I have untreated cancer? The U.S. Preventive Services Task Force now recommends against PSA screening for men over 70, period. Not talk to your doctor about it. They actively recommend against it for this age group, and multiple major medical organizations agree. Yet walk into many primary care offices, and they'll automatically order a PSA for any man over 50 without even discussing whether it makes sense. This is partly defensive medicine. Doctors worry about being sued if they miss a cancer, but it leads to massive overtreatment and harm to elderly men. I want you to think about your quality of life right now if you're a man over 70, or about your father or grandfather. Would you rather live with the tiny chance that you have a prostate cancer that might eventually cause problems? Or would you rather risk the very real possibility of incontinence, impotence, and surgical complications from treating a cancer that probably would never have bothered you? There's no perfect answer, but it should be your informed choice, not something done to you automatically. The third screening we need to talk about is something that sounds so harmless, so obviously beneficial, that people think I'm crazy when I suggest avoiding it. Routine colonoscopy for colon cancer screening after age 75, especially after 80. Now, colon cancer screening is genuinely important for people in their 50s and 60s. Finding and removing polyps before they become cancer is one of the true success stories of preventive medicine. But like everything else, there's an age where the risks start to outweigh the benefits, and most experts agree that age is somewhere between 75 and 84 most people. Here's what makes colonoscopy different from a blood test or imaging. It's an invasive procedure that requires anesthesia. You're sedated, a scope is inserted through your entire colon, and if polyps are found, they're removed right then. For a healthy 55-year-old, this is relatively safe. For an 80-year-old with diabetes, heart disease, and maybe kidney problems, It's a very different risk profile. The preparation alone, the powerful laxatives you take to clean out your colon, can cause dangerous dehydration and electrolyte imbalances in elderly people. The sedation carries risks of confusion, falls, and respiratory problems in seniors. And the procedure itself can cause bleeding or, rarely, perforation of the colon, which is a surgical emergency. Now add to this the time factor. Most of the benefit of colon cancer screening comes from finding and removing polyps before they become cancer. But polyps typically take 10 to 15 years to turn into cancer. If you're 82 years old and you find a polyp, there's a very good chance you'll die of something else before that polyp would ever have become a dangerous cancer. But you'll still face the risk of the procedure to remove it. And if colon cancer is actually found, the treatment, surgery, chemotherapy is extremely difficult for an 80-plus-year-old body to handle. The guidelines reflect this reality. Most medical organizations say screening can stop at 75 if you've had regular previous screening with normal results. And they recommend strongly against starting screening after 75 if you've never been screened before. After 85, virtually all guidelines say to stop screening entirely because the harms clearly outweigh any possible benefit. Yet I've talked to people in their late 80s whose doctors are still pushing them to get colonoscopies. This is medical care that's doing more harm than good, plain and simple. Let's shift gears to number 4, and this one is really going to surprise you. Routine annual EKGs or stress tests for heart disease screening if you have no symptoms. Before anyone panics, I'm not talking about people with known heart disease, people with chest pain, or people having symptoms. I'm talking about the routine screening tests that some doctors order every year for older patients just to check for problems. These tests cause an enormous cascade of unnecessary further testing and interventions. Here's the problem. EKG abnormalities are very common in older people and usually don't mean anything is wrong. Your heart's electrical system changes with age. You might have tiny irregularities that show up on an EKG, but will never cause you any problems. But once that abnormality is documented, it needs to be followed up. Now you're getting an echocardiogram. Maybe a stress test. The stress test shows something ambiguous, which happens all the time because these tests aren't perfect. Now you're heading for a cardiac catheterization, which is invasive and carries real risks of stroke, kidney damage, and vascular complications, especially in elderly patients. And here's the real kicker. Studies have shown that routine cardiac screening in people without symptoms doesn't reduce heart attacks or save lives. It just finds things that lead to more tests and treatments. The American College of Cardiology and other major cardiology organizations recommend against routine screening EKGs in people without symptoms. But many primary care doctors still order them, especially for seniors, thinking they're being thorough. Instead, they're often starting their patients down a path of unnecessary interventions. I knew a man, 73 years old, active, walking 3 miles a day, no chest pain, no shortness of breath. His doctor ordered a routine stress test. The test showed some borderline changes. He ended up getting a cardiac catheterization that showed mild blockages that cardiologists would normally just manage with medication. But now that they'd seen them, they felt pressure to do something. He ended up with stents. The procedure caused a small stroke that left him with weakness on one side. His quality of life plummeted. And here's the tragedy. He probably would have been fine just walking and taking his cholesterol medicine like he'd been doing all along. The lesson here is that finding something isn't the same as benefiting from finding it. Sometimes ignorance isn't just bliss, it's actually healthier. At least when we're talking about screening for problems that might never have caused symptoms or shortened your life. Finally, let's talk about number 5. Routine bone density scans for osteoporosis after you're already in your late 70s or 80s. Especially if you're already on treatment or have chosen not to take osteoporosis medications. Bone density testing, or DEXA scans, are important for women in their early postmenopausal years and for anyone at high risk for osteoporosis. But continuing to get them repeatedly in your late 70s and 80s often provides no useful information and can lead to overtreatment. Here's why. First, we already know that bone density decreases with age. Getting repeated scans that confirm you still have low bone density doesn't change the management if you're already on treatment, or if you've decided treatment isn't right for you. Second, the medications for osteoporosis, particularly the bisphosphonates like Fosamax, come with their own risks that increase with age and length of use, including jaw problems and unusual fracture types. For a very elderly person, the benefit of slightly reduced fracture risk has to be weighed against medication side effects and the reality that falls, not bone density, are usually the bigger issue in fracture risk. Third, and this is important, if you're in your 80s and frail, a hip fracture is serious regardless of whether it happens because of osteoporosis or just because of a fall. The real prevention comes from fall-proofing your home, maintaining muscle strength and balance, and managing medications that might increase fall risk. Getting another bone density scan doesn't address any of that. It just provides a number that might lead to your doctor increasing your medication dose or adding another drug, neither of which will help you if you fall and break your hip because of a throw rug or dizziness from your blood pressure medication. Many experts suggest that if you're over 80 and you've been getting regular bone density scans, you can probably stop unless there's a specific reason to monitor, like you're starting a new medication that affects bone health. The scans expose you to small amounts of radiation, they cost money, and most importantly, they often lead to medication adjustments that don't actually improve outcomes for very elderly people. So let's bring this all together because I don't want anyone to misunderstand what I'm saying. I am absolutely not telling you to avoid all medical care after 70. What I'm telling you is that medical care should be personalized, thoughtful, and focused on what actually improves your life and longevity, not on blindly following screening schedules designed for younger people. The best medical care for a 75-year-old is completely different from the best care for a 55-year-old, and different still from care for a 45-year-old. Here's what you should take away from this. First, every medical test should be a choice, not a reflex. Before you agree to any screening test, ask your doctor these questions. What are we looking for? What will we do if we find it? How will finding this change my treatment or my outcome? What are the risks of the test itself? What happens if I don't do this test? These are not rude questions. They're smart questions that any good doctor should welcome. Second, your overall health status matters more than your age alone. A robust, healthy 75-year-old with no other medical problems and a family history of living to 95 might benefit from screenings that make no sense for a frail 72-year-old with diabetes, heart disease, and kidney problems. Life expectancy isn't just about the number of candles on your birthday cake. It's about your overall health trajectory. Third, quality of life should be part of every medical decision. There's an old saying in geriatric medicine, the goal isn't to add years to your life, but life to your years. If a screening test is likely to lead to treatments that will make your remaining years less enjoyable without clearly extending your life, that's crucial information in your decision-making. Fourth, it's okay to say no to your doctor. Many seniors grew up in an era when you didn't question doctors. You just did what they said. But medicine has changed, and patient autonomy is now recognized as fundamental. If your doctor recommends a screening and you don't think it makes sense for you after asking questions and considering the information, you have every right to decline. A good doctor will respect that decision, even if they disagree with it. Finally, have these conversations before tests are ordered, not after results come back. Once you have a result, especially an abnormal one, it's much harder to avoid the cascade of follow-up testing and treatment. The psychological burden of knowing something is abnormal, even if you intellectually understand it might not matter, is very real. Prevention is always easier than damage control.